Hello, and welcome to this EMJ webinar focusing on autosomal dominant polycystic kidney disease in children. My name is Evgenia Kutsuki and I'm the editor of the EMJ family of journals. Our presenter today is Jalila Mekhali, who is a member of the editorial board of EMJ Nephrology. Professor Mekhali is a pediatric nephrologist and a professor at the University Hospital Leuven, Belgium. She trained in pediatric nephrology and transplantation in the University Hospital of Lyon and in Great Ormond Street Hospital in London, and is currently leading the pediatric ADPKD clinic and the PKD research group in Leuven. Professor Mekhali is very active in clinical and biological research, aiming at identifying and validating early biomarkers for ADPKD. She's the co-chair of the work group for autosomal dominant structural kidney disorders from the European Reference Network for Rare Kidney Diseases. Professor Mekhali, thank you very much for presenting this webinar. The floor is yours.
I would like to thank the EMG Health for giving me the opportunity to present the pediatric spectrum of children with autosomal dominant polycystic kidney disease and the current recommendation that are available. Here are my disclosure, as I have no conflict of interest because they are paid to my institution. I will start with an overview on ADPKD in adulthood before taking you through the pediatric spectrum of the disease. As a final part, I will introduce our global pediatric initiative of the ADPKD registry, and I will finish with some conclusion. The first case described with the possible ADPKD is the King of Poland, Stefan Batory, who died at the age of 53. And performing his autopsy, both surgeons Zigulits and Boschula describe his kidney large like those of a bull with an uneven and bumpy surface. Only in 1841, Pierre Reilly recognized as the first physician the pathological features of polycystic kidney disease. He wrote that the cystic degeneration of the kidney, where it can be detected or recognized during life, is an illness without cure. Since then, the identification of the PKD1 and the PKD2 genes, together with the drive to elucidate the functions of their encoded proteins polycystin-1 and polycystin-2, has led to an explosion of clinical and scientific interest in this disorder. And recently, tolvaptan has raised as the new disease-modifying treatment in adult ADPKD patients and is the only drug approved from the EMA and the FDA. ADPKD is a systemic disorder characterized by the development of multiple renal cysts, which progressively lead to end-stage kidney disease by the fifth decade of life in 50% of the patients. It affects 1 in 1,000 live births, resulting in more than 12 million patients worldwide. However, it is very important to highlight that 2/3 of the people do not know that they have the disease, and it is clear that ADPKD is still underdiagnosed. It represents the most common hereditary kidney disease and the fourth common cause of renal replacement therapy. It is caused by loss of function mutations in PKD1 or PKD2, which respectively encode the polycystin-1 and the polycystin-2. Recently, new mutations have been described in other genes, such as GANAP, DNA GB11, and ILG9, causing a milder and rare phenotype of the disease. The severity of the disease depends indeed on the type of the mutation, as the patients with truncating mutation have the most severe prognosis, followed by the ones who have non-truncating mutations. Patients with PKD2 mutations have a milder disease phenotype with a later age of onset and slower progression of kidney failure. However, even in same families, there is a high phenotypical variability, and until now, no genotype-phenotype correlation have been found. The main manifestation of adult ADPKD are renal, with nephromegaly in the majority of the cases, end-stage renal kidney disease, as mentioned before. However, they might have hematuria, proteinuria, urinary tract infection, and also 28% suffer already from pain. Besides the renal manifestation, as ADPKD is a systemic disease, several other organs are affected with extrarenal manifestation, including pancreatic cysts or also hepatic cysts, resulting in polycystic liver disease. Hypertension represents the predominant cause of morbidity and mortality in adult ADPKD. More than 60% of the patients suffer from hypertension, and this even before renal impairments. The pathophysiology of this hypertension is multifactorial. However, the cyst compression of the renal vasculature play certainly an important role. The benefits of treating hypertension in ADPKD have been matter of several studies, but I would like to highlight the most important one, the HEALTH PKD study group, which demonstrated that intensive blood pressure lowering, including goal of 95, 60 or 110/75 instead compared to the standard blood pressure target, had a significant benefit on TKV, left ventricle, mitral insufficiency, and albuminuria. Furthermore, a lot of work has been performed to categorize the disease severity in ADPKD patients. The Mayo Group developed this unique model categorizing patients based on the kidney volume into 5 classes, from A to E. As you can see, the group of A are the ones with the smallest kidney and with the best prognosis and the slowest associated kidney function decline, while the one with the largest kidney from class E in red have the worst prognosis. This classification help counseling patients and help also for designing clinical trials. So in addition to the mentioned importance of genotype and TKV, several other characteristics have been used to generate prediction models and help to stratify ADPKD patients. Indeed, patient characteristics, even gender, and also clinical findings such the prevalence of hypertension before of the age of 35 years, laboratory finding, and environmental factor have actually been included in this model. As I mentioned before, there is currently no cure for ADPKD, and dialysis and transplantation remain the ultimate therapy for patients with end-stage kidney disease. Although the enhanced understanding of the complex signaling pathways and the cellular changes had stimulated the development of targeted therapies which directly inhibit the development or growth of the cyst, here illustrated in a simplified figure, tolvaptan has raised as a new disease-modifying treatment in adult ADPKD patients with rapid progression. Indeed, as vasopressin has been shown to accelerate cyst growth in both animal and human models of ADPKD, tolvaptan as a vasopressin antagonist has been studied in the TEMPO trial, including patients from 18 to 50 years of age with EGFR above 60, and showing a reduced kidney growth with a delay of the GFR decline. In between, other studies have been done and confirmed the benefits of tolvaptan through all the stages of CKD in ADPKD patients. In a very small proportion of patients, there were elevation of liver function tests, and therefore it is mandatory to follow up carefully the liver function under tolvaptan. However, we need to highlight the more important side effect of the diuretic effect with thirst and polyuria. And now let's move on the pediatric spectrum of ADPKD. Until recently, ADPKD was considered as an adult onset disease, as many patients remained polysymptomatic during the first 3 decades of life. So, whether asymptomatic children in families with a positive history of ADPKD should be tested for the presence of the disease remains a matter of controversy. No guidelines are available, and all pediatric data were scarce and only derived from small cohorts. So, the main arguments against testing of children in families with ADPKD are the current absence of cure or an effective treatment preventing cyst formation and cyst growth in childhood. The fear of being unable to obtain life or medical insurance, and the possible psychological stress of medicalizing this population. On the other hand, we might have the opportunity to intervene in the natural history of the disease by targeting modifiable aspects of prognostic indicators, such as hypertension or proteinuria. So, high recurrent risk that subsequent siblings will follow a similar early manifesting clinical course. Furthermore, the possible psychological stress is not only linked with the certainty of the diagnosis, but also staying with its uncertainty. We have noticed in our daily practice that a lot of families with ADPKD got confusing with different attitude and different approaches of the healthcare givers. That's why in 2017, we conducted a survey assessing the attitude of pediatric and adult nephrologists and geneticists. A total of 410 clinicians responded to the online survey, including 216 pediatric nephrologists, 151 adult nephrologists, and 43 clinical geneticists. Very important to highlight that this online survey was conducted before the European ADPKD Forum report, the KDIGO consensus, and before the approval of tolvaptan. So while the 3 groups agree to encourage clinical testing in asymptomatic ADPKD minors and adults, only geneticists would recommend genetic testing in asymptomatic at-risk adults. Very important was that all the respondents agree that informing an at-risk minor about his or her genetic risk for ADPKD at adult age should be a shared responsibility of the professional caregivers and the parents. So uniformity in approaching and counseling these ADPKD families is really mandatory. Furthermore, the important aspect of the pediatric ADPKD management is very difficult because the balance on not medicalizing asymptomatic individuals and on another side not missing treatable disease manifestation at early stages is very important. Accumulating evidence support that cyst formation starts in childhood or even in utero. Several reports and recently an international consensus paper including pediatric, adults, ADPKD experts, geneticists, and patient representatives provided clinical practice recommendation on diagnosing and monitoring children with ADPKD. So, beside the well-known adult onset of the disease, ADPKD presents a high phenotypic variability, and it's spanning over the entire age range, including childhood onset, very early onset, and even severe prenatal cases who mimic ARPKD. It is reported in the literature that only 2 to 5% of ADPKD patients present in childhood with a broad clinical and diagnostic spectrum. Some of them are presenting to our clinic with symptoms, even are diagnosed prenatally with big hyperechogenic kidneys. Some of them are incidentally diagnosed, and we find renal cysts when performing an ultrasound for such as abdominal pain. And last group is undergoing active clinical testing. So comparing to the symptoms of adult ADPKD, children are also presenting with renal nephromegaly, accelerated renal growth, with cysts with growing number and size, but also UTI, hematuria, and proteinuria. However, the extrarenal manifestations are rare in childhood, except the hypertension. Indeed, as mentioned previously, cardiovascular disease is the predominant cause of morbidity and mortality in ADPKD patients. A meta-analysis revealed that 20% of ADPKD children had hypertension in 14 studies, including over 900 patients, with an increased incidence with age. Very surprising, the Colorado group demonstrated that ADPKD children with blood pressure at the higher end of normal, percentile 75 to 95, have already an increased left ventricle mass index compared to the normotensive peer. The same group have also demonstrated that over time, children with high blood pressure demonstrate a greater increase in cyst number and fractional cyst volume versus children with normal blood pressure. Recently, a large European study including more than 300 ADPKD children using the 24-hour ambulatory blood pressure monitoring demonstrated that even if children are asymptomatic, 35% have confirmed hypertension, 52% demonstrated non-nocturnal dipping, and 18% presented with nocturnal hypertension. This study pointed out the high prevalence of hypertension in children even before developing any symptoms, and argued the need of active screening of this treatable disease modifier. Also, proteinuria and microalbuminuria are common in children and correlate with hypertension and with the severity of renal disease. This has been reported in 20% of 508 children in 8 studies. Proteinuria is known to be a marker of CKD, and its management might have prognostic benefit in the disease progression. So, based on the international consensus paper, and together with my colleague Charlotte Gimpel and Carsten Bergman, we propose a diagnostic and a workup algorithm to facilitate the management of ADPKD children and their counseling. So I'm going to go briefly through the algorithm. For the children with the incidental finding of kidney cysts on ultrasound or on prenatal screening, the question of family history should be addressed first. This might require ultrasound examination on the parents or even the grandparents if the parents are younger than 40 years. If there is no family history, further workup for other kidney diseases might be done. However, in a case of a positive family history, a regular monitoring should be performed for a childhood manifestation of ADPKD. On the other side, if you have an asymptomatic minor at risk with a positive familial history, the first important step is to counsel the parent and the child and to have an in-depth discussion with them with the pro and the contra of diagnostic testing. It is considered equally valid approaches to clinically screen for hypertension or proteinuria without genetic testing or without performing any imaging, either by screening by ultrasound or genetic method. However, it is very important to highlight that if the decision of the parent and the child to not screen, the parents need to be aware that it's their responsibility to inform their children when they become adults that they have the risk to have inherited the disease. So now I will go in depth in the recommendation of the regular follow-up. I will start first with the hypertension, as it represents the main treatable disease manifestation of ADPKD. And I would like to go through the current recommendation that monitoring the blood pressure in all children at risk or diagnosed with ADPKD need to be done at least once a year. The preferred method would be the 24 hours ABPM. However, we can just perform it from the age of 5 years. If hypertension is diagnosed, ACE inhibition or ARB are the first-line treatments. And we aim to target the blood pressure below the percentile 75, although we think that might be more beneficial to target it under the percentile 50. However, clinical trials are there needed to confirm our targets. In parallel, monitoring of the proteinuria is also recommended, and in terms of drug choice, the ACE inhibition and the ARB are the primary treatment option. So in addition to this, it is important to explain that lifestyle approaches are also very important in the management of ADPKD children. As higher salt intake is associated with worse kidney outcomes in the general population, as well as with higher kidney volume and growth in ADPKD adults, lowering salt intake is recommended from childhood. Similarly, deliberate high water intake can suppress endogenous vasopressin and can be assumed to be beneficial. However, observational studies do not confirm this benefit, and currently the ongoing larger randomized trials are awaited. Also, sport is very important, and managing obesity as it represents an independent risk factor of faster loss of renal function in adults with early ADPKD, health lifestyle is very important. No smoking and avoiding of nephrotoxic drugs such as NSAID. We also advise to use estrogen-free contraception. All these lifestyle approaches are more detailed in the ADPKD roadmap and can be uploaded via the link. Last but not least, recently tolvaptan have been studied in ADPKD children. It was a 3 years follow-up study where the results are expected soon from the first year, which was a double-blind, randomized, and controlled trial. These results will be presented in the next ERA EDTA meeting. So, although the interest in ADPKD children is growing, there is an unmet need in more research. We need to work on the early disease progression factors to be able to stratify the patients and select the rapid progressors who will benefit from treatment. For this, we initiated together with Max Libaud from Cologne and Franz Schäfer from Heidelberg the ADPKD registry for gathering information on large ADPKD children. This is an online platform aiming to generate data on incidence, presentation in childhood, to identify progression factors in children, to assess the effects of the current management, such as our ACE inhibition in hypertension and proteinuria, and finally, to provide international guidelines or recommendations. So all the patients younger than 19 years of age with the diagnosis of ADPKD will be included. A detailed basic data questionnaire including genetics, family history, and initial diagnosis will be used in combination with retrospective data such as the prenatal characteristics and the yearly follow-up prospective data. We will include, beside the clinical characteristic, also radiological and laboratory findings. At the moment, this collaborative project is composed of 91 centers of pediatric nephrology through the world from 33 countries, and we already included 1,219 ADPKD children. The numbers are growing daily as a lot of new centers joined and are actively included. So Europe, Africa, Asia, and South America share one common database, while Australia, UK, and North America had already their own database, as in Australia, Kitchen, in UK, Radar, and in North America, the hepatorenal fibrocystic disease database. So we made the effort to harmonize all these databases, and we are all together working together in this initiative. So I hope that I convince you that ADPKD is not purely an adult disease with late onset. Progress on understanding ADPKD in children is increasing. We already succeeded to propose an international consensus on the diagnosis and the management of ADPKD children, and we are working as a pediatric community in this worldwide registry to improve our knowledge. I would like to highlight that the importance of regulatory screening of hypertension and proteinuria for these children might be beneficial for the long-term outcome. Furthermore, the clinical testing of at-risk offspring needs to be discussed with the parents and the child. The results of the first international study of tolvaptan in ADPKD children are expected soon, and these results might really change the landscape of ADPKD children. In between, we need to continue working on pediatric scoring system to allow an individualized care. So before ending this presentation, I would like to thank the PKD research group and all our collaborators from our hospital and beyond. And I will finish thanking the ADPKD children from my clinic who helped to move on in the research and who made these artistic kidneys. And I thank you very much for your attention. And I invite you to join our initiative of the registry to include children or adults with the childhood presentation. And I thank you.